Hi, everyone. All right. I think we're ready to get started. Or not. All right, so my name is Nathaniel. I'm currently doing 4th year. I've done a BMed-Sci before, which is why many of you will probably not recognize me as being in the year above. We have a pretty small turnout today, and one thing I would like to say is, I'm not sure how many people here have already had a neurology rotation of any sort. Hands up if you have. All right, that's most people. Keep your hands up if you have absolutely no idea what happened during that time. Yep, so as I expected, neurology rotations can be quite variable. Sometimes you can have a great team that'll teach you lots. Other times it feels like every consultant has Asperger's and you have no one's taught you anything the entire time. So what I'm trying to do today is not going to be go through ridiculous detailed stuff. What I want to tell you is most of the things you're going to get examined in 3rd year in neurology are fairly basic, but you need to know the basics quite well. So that's kind of what I want to encourage, is not to get too confused when you see all these rare syndromes coming up and all these random things that you've never heard about in a rotation, because most of those things aren't important. You just need to know the really basic things, and they actually examine a bit of neuroanatomy and just the basics of every clinical exam. What does this sign mean, or what sign do you expect? It's not going to be anything too difficult. With that, the first thing I'd like to say is, if anyone has actually any questions from neurology or 3rd year in general that they want to ask, we've got a small group here, so I don't want to make this a lecture, but rather if we make this interactive, it's probably better for everyone. I mean, most people are just going to be watching this at home. You guys have all made the effort of coming here at 6:30 on a very cold Monday. So I'd like to benefit you guys by actually allowing you to ask anything at all that has been on your mind, either from neurology or 3rd year in general, any questions you guys have. All right, I assume no one would be brave to put their hands up, but please stop me at any point if you have anything to ask, okay? You don't want to have come here when you could have just watched it at home. You're better off asking as many questions as you possibly can. Anything that you've encountered that you're not sure if it's relevant to 3rd year, if you're just not familiar with it, please don't hesitate to ask me, okay? So my biggest tip for 3rd year would be start doing OSCE practice right now. Has anyone already started doing OSCE practice? Hands up if you have. One brave hand up. All right, I started doing them about this time, so early 2nd semester, and I think that's really helpful because you're going to have 2 exams at the end of the you guys have like a 3rd pathology exam. I can't give you any tips about that. I'm just really sorry about it. But what I can say is you've got the OSCE and the EMQ. The EMQ is just recognition. Have you seen this before? It doesn't matter if you have it at the tip of your tongue. You just have to recognize it that you've seen it in the past. The OSCE, on the other hand, you have to answer questions out of the blue, and it tests your thinking skills quite quickly. You have to very quickly come up with diagnosis, ask questions, and things like that. So in my opinion, the OSCE is much harder. People definitely did worse in the OSCE than the EMQ in general last year. So I think if you start doing practice OSCEs now, I started doing them once a week. Every week for a good 2-3 OSCEs each with an OSCE partner, and that helped a lot from this time. So I think right now is a good time to start. Just find all those practice OSCEs and do that. I would highly recommend ignoring the matrix. I know lots of 4th years will tell you, oh, you've got to do the matrix. You make sure you've got nice notes in every single condition in the matrix. The matrix isn't anything new. It's just if you've missed something, you never had a rheumatology rotation, and you're at Eastern, so you're teaching shit, that you can look back and say, oh, these are the conditions I need to look up for rheumatology because I've never encountered it before. But if you're, if you've had that rotation or they've done teaching on that, just check that you haven't missed anything. Don't make the matrix the goal of your study, because I saw a lot of people do that, both in my year level and the year above, because I have a lot of friends who are now final years. And a lot of people who did that did a lot worse than they should have, because they just concentrated so much on making sure their matrix is finished, writing notes and everything, that they didn't really practice clinical skills in OSCE. So I highly recommend just putting the matrix to the side and only using to double check if you actually have missed something, any actual gaps in your knowledge. And I really recommend just doing lots of practice questions, practice OSCEs. It's a much better way of studying and testing your knowledge. And also don't bother with textbooks at all. Like Oxford Handbook of Clinical Medicine is more than enough detail on everything. If you need to check management of something, ETG would then be your guide, nothing else. And they didn't ask us, they asked us one management question the whole of last year. So I wouldn't stress too much about management. I'd really just focus on knowing conditions and diagnosis. So neurology in third year specifically is going to be assessed probably in your MCRs, but you've already figured out that the key to MCRs is which site you're in and who your examiner is, not how good you are. So, so nothing we can do about that. OSCEs is usually 1 to 2 neuro stations. So last year we had 1 neurology station. It was a cranial nerve examination in 7 minutes, and they asked a couple of questions about hearing after that. So you should be very able to answer any questions about all of the signs that you'd expect to get in an upper limb, lower limb, or cranial nerve examination. So if they ask about Rene and Weber's, you should be able to answer that, and that's what we had last year. And I'd say that for anything in the examinations. The history station, so the year before, there was an upper limb exam where you had to know your myotomes, which I think is a bit of a dick move, and also you had to take a history of headache. So 2 neuro stations in 1 year. So I think you should be prepared for at least 1 neuro OSCE station. EMQs, usually they give about 7 EMQs in neurology, and they're usually not that difficult. And the PATH exam, good luck to you all. I think I've already said all of that. So the history stations is usually going to be headache or seizure. So if it's headache, you have to diagnose what type of headache the patient has, and we'll go through all of that. And often in a seizure is about asking all the right questions. Is this a seizure or is it not a seizure? That's usually the big question you have to know how to answer in third year, because lots of people come in and say, oh yeah, this patient had a seizure, but they could have had a faint. You know, just the other day, my dad fainted and he started twitching, but it wasn't a seizure. Most people, when they faint, will have a small twitch or something like that. Examination, you can usually expect a neuro exam, and Monash loves giving them to you. So I would practice those to death. Literally be able to do them in 5-7 minutes. They'll be reasonable. So the cranial nerves are 7 minutes without things like visual fields and blind spots and the really time-consuming stuff. But you have to do them fast. So I'd be really practicing the examinations over and over until you don't have to actually think what comes next. You just regurgitate. And if you miss a couple of things, it's not the end of the world. But I wouldn't be pausing in my examinations because that costs you too much time. That's what I just said. So the way I'm going to do this is I tried to make this a bit different to just disease by actually picking out different presenting complaints and saying, okay, if patient comes in with weakness, what are the things to be thinking of? How do you work that up? Turned out to be a lot more confusing than I imagined it to be, and I didn't have time to change it back. So we're going to leave it with this approach. It'll probably confuse the crap out of you. So just stop and ask me if you have any questions. So first things first, neuro OSCEs and history OSCEs. So the systems review for neurology is super complicated. There is a very dirty mnemonic floating around. I'm not sure if any of you would have heard it from Julian, and I may have taught it to him. But I would think that in third year, systems reviews are generally a bad idea with some exceptions, like chick toads for infectious diseases. That one you just have to do, and we had a fever in a return traveler station last year, and you just have to go through every single thing. But in neurology, the systems review ends up with headache, neck stiffness, seizures, loss of consciousness, coordination and gait, all of your senses, sight, smell, that looks shit. That was going to happen. Hearing, taste, touch, and then everything motor with speech, weakness, gait, and then even autonomic symptoms like bowel, bladder, and any, if you feel dizzy when you stand up. That's a lot of things to remember. I do kind of group them in sensory, motor, random shit to do with your head, and autonomic. But it's too difficult to remember all of these things. I would try to just have a few of them, and then more importantly, really go through with an OSCE station, what are your differentials? And that's basically what I just said. So what I would do every time you have an OSCE, and like I said, start your OSCE practice straight away. You have 2 minutes reading time before each station. That hasn't changed, right? Practice with 1.5 minutes because you're going to have to walk from one station to the other. You might forget things. You might have to go down a set of stairs. If you were at Frankston last year, they wouldn't give you the stem until you walked into the station. Fantastic. Didn't happen to me. It happened to the guy who topped the OSCE last year, so it obviously wasn't a problem. But what I am saying is practice in 1.5 minutes, Having that piece of paper that you write the same thing. So WWQQAA, your past, family, social history, drugs history, just all of those headings so you don't forget them. Do that as quickly as possible, and then try to go into a differential list. And I would do that before you walk into the OSCE. I'm sure many of you have heard this time and time again. Come up with some differentials and questions that you're going to ask, 1 to 3 questions per differential. And that's better than a systems review. And just fall back to systems review if you have completely no idea or you've got some time left. So, like I said, history will most likely be headaches and seizures. So let's start with our first OSCE. So patient X presents with a headache. I'm going to give you all 30 seconds to write down as many differentials as you can. And let's practice this because that's a better way of doing it. Then just look, and please don't look at the next few slides. That will give away all the answers. All right, okay. How many differentials did people get? Yell out numbers. 7, 12. I only asked for 9, so I don't know how you got to 12. But okay, let's keep going. So first thing, did anyone put up stroke as a differential? Hands up if you did. All right, stroke can never give you a headache. That is a lesson to say. So people get a lot of things confused in neurology. It feels like everything happens in the head, it's going to cause the same things. Headache is not a presenting complaint in stroke. Lots of different things can be, and we'll go through that. So cross that out of your list. I know a lot of people get that confused and it's never explained. It is not a differential. So if a patient presents with a headache, these are the 9 differentials I would expect you to be putting down, and we'll go through exactly how to work through that. So how many people had attention headaches? Hands up. Hands up if you had cluster headache, migraine, meningitis, temporal arteritis, increased intracranial pressure in general, and anyone had benign intracranial hypertension? Good job. Brain tumor? Anyone a brain tumor? Yep. Subarachnoid, subdural, and extradural. So it can seem really daunting. How the hell do you think of all of these things? Did anyone have any differentials that I didn't mention? Sorry? Okay. Did anyone have any more relevant differentials that would come up in an OSCE? Possibly, but you're not going to get examined in ophthalmology in 3rd year, so I would not think of anything ophthalmology ever in 3rd year. Okay, so how the hell do you think of all these differentials in a minute and a half? It's very daunting to think of that, and I'm not going to tell you you have to think of absolutely every single one. You have to think of the most important ones. So the most important thing with headache is the time course. That actually will already get you down to about 3 differential diagnoses. There are also risk factors and triggers that you need to look for. And even then, even if you're already quite obvious what the diagnosis is, in an OSCE, you should still ask a few questions from each differential you have, just to show the examiner. Remember, the OSCE is not real life. It's not about how good you are as a doctor. Really, in reality, if a patient comes in describing a perfect migraine, you're not going to ask if they have any, symptoms of a hemorrhage or something like that. If they've had several episodes of the same headache, they're not going to be thinking of extradural hemorrhage or something like that. But in an OSCE, you should ask, oh, have you had any trauma to your head? Do you have any history of polycystic kidney disease, etc., etc. So in an OSCE, just ask these things, even though it seems ridiculous, they still always going to be marks for ruling out other differentials. So the best way to think of headaches is there are 3 groups. A new acute onset headache, which is generally serious shit. Episodic acute headaches, which are less serious usually, or a chronic progressive headache. So what do I mean? Either a headache that is the first time they've had it and it's a really sudden or pretty sudden onset headache. It's a headache that comes on suddenly, but they've had lots of episodes throughout their life, or a few episodes at least. Or a chronic headache that just has been getting worse and worse for months, years, weeks, depends on the cause. So what I'm trying to say is there's a lot of possibilities here. And the time course is already one of the most important things there are. So now this list still seems really difficult to remember. So everything in medicine, if you think of in a list of 3, all the full slides will come up. Don't bother taking photos. I'll be putting the ones with the answers up later as well. I should have said that first. So always think of things in lists of 3. Otherwise, it's too difficult. Okay, it's too hard to remember 5 here, this, there, there. There's 3 that you need to remember for each category. So a new onset headache is a subarachnoid, meningitis, or temporal arteritis. If it was an extradural hemorrhage, they would tell you if it was trauma. That's not going to be your OSCE station. It's not patients being hit in the head with a bat and now they're unconscious here. That might be the resus CPR station. Episodic acute headaches, migraine, tension headaches, and cluster headaches you need to be thinking of. And chronic progressive headaches, you need to think of subdural hemorrhage, brain tumors, or benign intracranial hypertension. And not all of these are that important, but what I'm saying is lists of 3s are the best ways to remember things. So the risk factors is a really good way as well of narrowing it down. The STEM will already tell you half the time what the diagnosis is. So now it's really annoying when the person you're going to pick on the entire lecture doesn't turn up. But let's assume if Nathan Hanegbi is a 21-year-old male with headaches, what headache type are we thinking of the most here? What's going to be your differential, the top differential, going into this OSCE? Someone say something louder. Sorry? Possibly, look at the words we've got here. Young, male. Why is the word male important? Which headache type is more common in males? Cluster. Okay, so young male, you're thinking cluster headache first of all. Nathan Hanegbi is a 60-year-old woman with sore joints and a headache. What are we thinking of this time? Temporal arteritis, exactly. So if you ask, do you have sore joints? In a Monash OSCE, it's going to be temporal arteritis straight away. And now if Nathan Hanegbi is a 30-year-old woman on the pill, what are we thinking of? Why did I specifically mention the pill? Yeah, migraine. Okay, so even then, even when the answer is obvious, you still need to ask questions to rule out all your other differentials, but half the time your OSCE will tell you the age and gender of the patient, and that can already help ruling things in and out. Whoops. Okay, so to rule in and out each of the differentials, you should always have a few questions that you're thinking of that will include the risk factors and causes and triggers. So if it's an extradural hemorrhage, what questions do you want to ask the patient? Give me 3 questions. Yeah, any trauma. That's definitely the most important question. Anything else? Yeah, so usually they have like the lucid then dead thing with extradural hemorrhage. So did they have any head trauma? And then were they completely well and then suddenly deteriorated quite badly? What questions do you want to ask them if you think it's a subarachnoid hemorrhage? Yep, so does it feel like a thunderclap? Great. Any other questions? Okay, it's important. Any other questions? Yeah, what did you say over there? Yeah, do you have polycystic kidney disease? It shows the Monash examiner that you know your buzzwords really well. You'd be surprised. Sometimes they can actually expect things like that. Any other questions you'd want to ask someone with a subarachnoid hemorrhage? I think that's pretty good. What everyone forgot though is meningism. Everyone thinks meningitis symptoms are just to do with meningitis. Seems simple. Meningism is some problem with the meninges. Subarachnoid hemorrhage is a bleed into the meninges, so it actually gives you the same symptoms as well. So the meningism triad is headache, photophobia, neck stiffness. That doesn't mean meningitis, so that's the first thing you're told. It also could mean subarachnoid hemorrhage. Okay, and it also kind of seems pretty similar to migraine as well. So there's a few differentials that actually applies to. So if you take the OSCE not last year, the year before, the patient came in wearing sunglasses. So, automatically, it's photophobia. So that doesn't mean it's meningitis, though. It could be meningitis, it could be migraine, and it could be subarachnoid. Okay, so don't think meningism equals meningitis. These 3 symptoms can cause all of that. So, yeah, renal history, thunderclap, worst headache of your life. They'll describe it, a 12 out of 10 headache, and also extremely sudden onset. It's like there was a pop. And they'll also have nausea and vomiting. Don't forget to ask basics like nausea and vomiting to like every headache patient. Meningitis, what things do you want to ask a meningitis patient if you're thinking meningitis? So go a lot faster if you yell the things out. Yep, so those three, yep, exactly. Meningism, someone said fever as well. Anything else you want to ask? Yep, rash, absolutely. Ask rash. What type of rash do you get in meningitis? Non-blanching, petechial purpuric rash. Yes, anyone, any other questions you guys want to ask a patient if you think they might have meningitis? Sorry? Phonophobia, they probably would. I mean, if you've got meningitis, you feel pretty unwell, but generally it's a buzzword for migraine. Photophobia is more meningitis subarachnoid as well as migraine. Phonophobia is more pointing in the migraine side, but again, if the patient's got a fever and a rash, I'm still going to think it's meningitis in the OSCE. Okay, so yeah, it's going to be a slightly longer answer than the subarachnoid. Confusion as well. And the one question I'd be being really impressed if anyone asked was, do you have a spleen? So actually, apparently there was not necessarily a mark, but the patient said, yes, I've had a splenectomy. If you explicitly ask that headache patient with the sunglasses for, have you had any surgical procedures in the past? You need to be that specific that year. Like this one mark, it's not going to make or break your OSCE. There's not going to be a difference between pass and fail. But why does it matter if a meningitis patient does or does not have a spleen? Specifically, why? Who said that? Great job. What are encapsulated bacteria? Yeah, which bacteria are encapsulated? Yeah, okay, you just need to say that first. Never give the full thing unless you're an ID. But yes, strep, Neisseria, and Haemophilus are encapsulated. What are the commonest causes of meningitis? Strep, Neisseria, Haemophilus. So a patient who's had a splenectomy is at higher risk of infections by these. Again, it's like, if you're a real keen bean, you're going to ask about their spleen. Temporal arthritis. What questions you want to ask the patient if you suspect temporal arthritis? Yep. So do you feel like a specific, artery? Like most people can see that artery, and so do you feel like pain over there? Sure, you can be that specific. Any more general questions or things that point to temporal arthritis? Jaw claudication. Yep, that's a buzzword. So if they get pain with chewing, that's a classic symptom of temporal arthritis. Any other questions you would want to ask this patient? Yep. So if they have any sign of polymyalgia rheumatica, so do you have shoulder and hip pain? So any girdle pain? Absolutely. Morning stiffness, kinds of things you're thinking of with PMR, because they're very common together. Chances are the patient, they'll give you a bit of a clue if that's where they're going. Anything else you want to ask a temporal arthritis patient? Perfect. Visual loss as well. Amaurosis fugax or actual continuous visual loss as well. Sorry? It's pretty sudden onset, yeah. You don't need to worry too much about that, though. Your eyes is fourth here. Okay, so yeah. Also, their age, you never diagnose temporal arthritis in someone under 50 as a blanket rule. The headache is going to be unilateral. Scalp tenderness as well, so they'll describe like combing their hair and having pain on doing that. Jaw claudication, shoulder and hip pain, like we said. Loss of vision is extremely important. There will be marks for that if that's what they're going for, because that's the thing we're worried about with temporal arthritis. Okay, migraine, what questions do you want to ask? Yep, so obviously, is there a history of this? Anything else? The pill, yep, are you on the pill? And I heard some muttering from that direction. Yeah, nausea and vomiting. It's very non-specific. Most of these will give you that, but absolutely. Anything else? Is there an aura of visual changes? So is there anything that warns it? Now, is the aura for migraine, is it always visual? What else could it be? Could be hemiparesis. Anything else it could be? Olfactory. Could be olfactory, yes. Anything else it could be? Auditory, yes. Anything else it could be? The answer is anything. Any neurological symptom could be, theoretically, the aura to a migraine, and some migraines happen just the aura, no actual headache afterwards. So I have a friend of mine who gets a migraine that is just vertigo and no headache afterwards. It's still a migraine. Okay, so any neurological symptom could technically cause a migraine, and that's because we have no fucking idea what migraine actually is. Okay, other questions, is it associated with the menstrual cycle? Any triggers, so chocolate, cheese, wine? poor sleep, anxiety, travel, all these are classic things that will trigger it. Not necessarily need to say them all, but I would have a few things. Any foods, chocolate, wine. Do you get them more if you have bad sleep? And yeah, ask a few other neurological symptoms. You don't need to necessarily go through them all, but absolutely think of your neurological systems review, just a handful of things to screen it. And absolutely, do you get any warning? And is there photophobia and phonophobia? Now, as we said, a lot of these things you've already asked. Is there photophobia? We've already asked it before, so you need to do this for every one of them, but I'm just showing you the questions you need to be thinking of with each of these. Tension headache, what do you want to ask? Yeah, band-like. Anything else you want to ask a tension headache patient? Yeah, are you particularly stressed? Okay, cool. And cluster headache, what do you want to ask for cluster headache?
Does it happen at a certain time during the year?
Mm-hmm. Perfect. Anything else?
At a certain time of the day.
Yep. Okay, so you be really specific with when does it happen, how long does it happen for, how many days do you get it for, is it at the same time, get all of these things. Anything else? Exactly. Be more specific, because if you ask your patient, do you have any autonomic features of your cluster?
Crying from one eye or excessive.
Yeah, teary, runny nose, anything weird like that. Absolutely. Okay, so yeah, and it feels pretty, it's pretty much like a stab, sudden onset type pain as well. Okay, so absolutely, great questions, guys. So together, everyone as a whole would do really well in anoscopy. All right, cool. Subdural hemorrhage. What do you want to ask? Or look for in the history, you might not necessarily ask. But age, absolutely. So elderly people at a high risk. What else? Why is age a risk factor for subdural hemorrhage?
Because your brain shrinks in the veins.
Yep, so subdural hemorrhage is the bridging veins between the brain and the meninges. So as your brain shrinks with age, unfortunately it does do that, there's more stress on those bridging veins, they're more likely to rip. What else causes your brain to shrink? Alcohol. So are you an alcoholic is a great question to ask, the subdural hemorrhage. Any other questions you want to ask? I think that's pretty good. And yeah, if it's been chronically getting worse, subdural hemorrhage can be acute onset, but often it takes a while, just slowly builds up and gets worse and worse, and the conscious state starts going down and down and down. So increased intracranial pressure, which is both benign intracranial hypertension and a brain tumor, two causes of it. What questions do you want to ask this patient, if this is what you're suspecting? There's a lot to get through, and I've been told I have to get out at 8, so the quicker we get through this, the more I can teach you or bore you. Sorry, are you a young woman who's overweight? Perfect. Perfect question for benign intracranial hypertension. Any other questions? If it's a brain tumor? Yep, that's actually with both of them. Why is that? Because if you're lying down, if you've got a CSF as a tube like this, if you're lying down, it accumulates in the head, causes the headache. Okay, so that's with both of these things. Is it worse in the morning, worse in lying down, better standing up? Yep, whereas if you've got low pressure, not that you guys are going to encounter this very much, but I once saw a patient with CSF rhinorrhea, so he had a fracture and he was leaking out of his nose. If he lies down, it's better because it goes back up, whereas if he stands up, it leaks out, and then it's very low CSF and he had a headache. It's pretty interesting. Okay, cool. So yeah, worse lying down, anything like that. What are symptoms of brain tumor, though? What questions do you want to ask that? Exactly. Do you ask your patient, do you have any focal neurological deficit? Depends who your patient is. But yes, you would go through a few systems. So do you have any weakness, any numbness, tingling, any changes in vision, anything like that? You don't have to go through them all, but always go motor and sensory at least. Okay, I don't know why I put papilloedema there. You can't ask your patient, do you have papilloedema? You can ask them if they've got visual change, though, which is what you're worried about with benign intracranial hypertension, because it's not benign. That's why they change it to idiopathic intracranial hypertension, because it can cause blindness in young obese women. Okay, and yep, worse with coughing and laughing as well is another thing you want to ask, because it also increases pressure, just like lying down. Cool. Now, just going through each of them, I think we've mentioned most of these things. Extradural trauma to the middle meningeal artery of the pterion, they go well then dead. The only investigation to worry about is an urgent CT brain, and the management will involve urgent neurosurgery to decompress this. Okay, so why do I have this picture there? I think it's very unlikely I'll give you a CT brain, but just in case, you should probably understand why it's convex as opposed to concave. Concave, like this, as we'll see, means subdural. Convex, extradural. How do you remember that? It seems complicated. It's all about pressure. This is an artery. Arteries are high pressure, so the blood is going to be spurting out, punching the brain. That's why you have this convex shape. Whereas subdural, it's a vein. It comes out drizzling slowly. It's a chronic kind of thing, bleed. And so it just goes concave around the brain. So it's just good to be able to tell those apart quite quickly. All of these things, blood shows up on CT really well. So CT brain is usually any kind of blood-related problem, your first line investigation in the brain. Okay, subarachnoid hemorrhage. So this is a picture of subarachnoid hemorrhage. So the blood, as you can see, is not in a specific place. It's all around the subarachnoid space, around the brain, in the ventricles, and so on. So the specific thing is a berry aneurysm. That's just what it's named after. I don't know why it's called berry. Who cares? But it's associated with polycystic kidney disease, as we've said, which means in an EMQ, if you see headache and bilateral bolotable masses, automatically put subarachnoid hemorrhage and move on. Okay, masses in the abdomen. I should make that clear. Investigations, you get a CT brain and or a lumbar puncture. You probably don't need to do a lumbar puncture, but it will show xanthochromia. Does anyone know what xanthochromia is? Yeah, yellow. So it's blood products. It's not blood. It's not exactly blood itself in the CSF. You actually look for xanthochromia, which is pathognomonic of subarachnoid hemorrhage. And the management supportive calcium channel blockers and then clipping or coiling. So Charlie, you're currently neurosurgery. What's the difference between clipping or coiling?
Coiling is like putting wire in the mechanism, so it forms a
good enough, yep.
Yeah, sweet.
And clipping?
I'm guessing it's like doing putting a rubber band over it.
Look, I'm not sure if they use rubber bands in surgery. I've never seen this, but yeah, no, good job. So clipping is a neurosurgical procedure. You go through, find the berry aneurysm, and you clip it from the outside. Coiling is endovascular. You bring the coil up in neurointervention and leave the coil inside the aneurysm. I've seen one of those. It takes forever. But yeah, so they're completely different things, even though they sound the same. You're not going to have to tell that apart. Okay, meningitis is very important. Meningitis could come up as your OSCE. So infection of the meninges of the brain. We've already talked about what the bacteria are. I think it's a very good idea to know which ones of these are gram-positive and negative. I'm not doing the ID revision lecture, but I will tell you, pay attention to that. You should know just the very common bacteria. Don't worry about, like, I don't know, you were telling me about Klebsiella before. Fuck that. But make sure you know the really important bacteria well. So if it says gram-negative Diplococcus and you're thinking meningitis, you know it's Neisseria. You need to be able to do that because that comes up all the time. Aseptic meningitis is where you don't find anything in the CSF sample, and that is classically HSV, which causes actually meningoencephalitis. So it's confusion. It's brain infection as well as the meninges. TB meningitis is also not going to come up in your CSF culture, and lots of random things like, I don't know. Doesn't matter. So as we said, meningism plus fever, possibly confusion. There are those two signs of neck stiffness, Koenig's and Brudzinski's. I don't think you'll ever see anyone actually do them on a patient, but just know that they mean neck stiffness from meningism, either in subarachnoid or meningitis, so that they're usually used to test meningitis. So my next question to you guys is, you suspect the patient in the OSCE to have meningitis. The examiner will ask you, what investigations would you like to order? Go. Write them down. Now. I'll give you 15 seconds. All right, time up. Okay, so why am I doing this? Because I recommend in a lot of these OSCEs, if you already know what the differential is or what the diagnosis is or what the differentials are, list the investigations you're going to order. It's a very common question to ask. Last year we had, as you guys probably know, a PE station, and they were asked what investigations were there, and they wanted also, although I think a lot of people forgot to give the to get a Doppler ultrasound of the cuff to actually look for the thrombus to begin with. So just you can't think of that on the spot. Think of it before going into the station. What investigations will they ask? And how do you do that? I made up this acronym of Gruber's. I don't know, it sounds stupid, but it works. to not forget any type of investigation, because everyone forgets your glucose, ECGs, urine tests. You just go straight for the blood test and forget everything else. So go through it systematically. What can you do at the bedside? What can you do in the urine? What can you do in the bloods? Are there any radiological tests? And then are there any special things like culturing the sputum or sending the patient to audiometry, as you had to in the neuro hearing station, but they explicitly asked. So anyway, I would just go through that framework to make sure you don't forget any classic investigation types. So what investigations did you guys write for meningitis? So let's go through the mnemonic. What things at the bedside? With the patient who's suspecting meningitis. Did anyone put any bedside tests? Yeah, can't hurt. Never hurt anyone to take a glucose, so I'll do it, particularly if the patient's coming in confused or something like that. You never know what the real cause is. Do glucose. Next, a urine. Any urine tests? Dipstick wouldn't hurt, but not that important. Bloods. What bloods do you guys want to order on this patient? Yes, always. What else do you always get? Yeah, what else? So like every time they begin with one investigation, would you like her to say FB, UEC, LFT, CRP? Just say that. Not going to hurt. They're always going to get that in hospital anyway. Cool. What else though? Yeah, what cultures? Yep, how many? All right, 2 is probably enough, but yeah, whatever they teach you. Get lots of blood cultures from multiple separate sites. Okay, yep, blood cultures because the patient could be septic. What else? Sorry? Yep, so that would be our special test, lumbar puncture. And what do you do with the lumbar puncture? Just puncture their spine, or do you do something with the... Sorry? Yeah, I'm asking this question because in the OSCE, they're not going to want to say, oh, do a lumbar puncture. You want to say, do a lumbar puncture and take the CSF for microscopy, culture, and sensitivity, just MCS, whatever things you get out of people's bodies. Okay, any special tests, any radiology or anything like that? Yeah, so it's not routine, but you'd consider it. I would mention it in the OSCE, say if there's any concern of raised intracranial pressure, I'd like to get a CT before doing the lumbar puncture. In reality, they don't really do it unless you really have a reason to think this patient. So did we miss anything? I think that was pretty good. All right, so in bacterial meningitis, what do you expect the lumbar puncture to show? Anyone? All right, so I heard low glucose over there. What did I hear over here? High neutrophils? Any other takers? Anything else? Raised protein. Anything else? Cloudy, turbid appearance. Exactly. So they'll want you to say all of those things. So it's easy to forget a few of these things. So it's easy to remember that the glucose is just eaten up by the bacteria. That's how I remember that there's low glucose. High protein because bacteria make protein. And the white cell count is high, predominantly neutrophils, which are also polymorphonuclear cells, and they love calling it that just to confuse the crap out of med students. In viral meningitis, what do you expect? Sorry? Yeah, predominantly in lymphocytes in the high white cells. What else? Clear, yep. Clear appearance. That's pretty good. Yeah, no one really cares. And a fibrin web means TB or fungal, just in case it's a buzzword on the EMQs. All right, so meningitis management. Again, like I said, don't worry too much about management in third year. But like I said, ID is probably the one place where that's not true. They will ask a couple of questions of what antibiotic to give. They do ask they do like to ask that. Also remember with something like meningitis, it's pretty serious. So if they tell you in the STEM you're in a rural area, you probably want to remove them from that rural area and refer them to somewhere else and whatnot. So just remember all these kinds of things. So treatment of meningitis, the antibiotic of choice is ceftriaxone. I'm not going to go through the reason why, but it's probably good to understand. And often you give dexamethasone as well to reduce brain swelling. So here we're going to EMQ from, I've stolen these off the faculty release papers. These are not necessarily past exam questions. They're only from the ones that the faculty has released, which I really recommend you guys do. I'm not saying why, I'm just saying it's a pretty good idea to do them and figure out the answer. So 70-year-old man who describes 3 months of increasing right temporal headache and scalp tenderness. In recent weeks, he describes pain on chewing and right visual disturbance. I hope I've made the answer obvious to everyone, yes? Someone yell it out, please. Everyone happy that M is the answer to this question? Good. Everything here is a buzzword for temporal arteritis, okay? Literally, it's just a description of temporal arteritis. But, not everyone has seen this before if you're like in a rural hospital or something. So temporal arteritis is the same as giant cell arteritis. It's a type of vasculitis. Important to know is all of the symptoms we've just described, visual symptoms as well, you must ask them. Associated with PMR, as we've spoken about. ESR is the specific test to order in this case. CRP is good, but ESR is going to be elevated. It's a classic thing for this as well. So always ask ESR if you're thinking temporal arteritis. And get a temporal artery biopsy. You must get it of both arteries, but don't delay steroids. You give the treatment immediately because you can't recover lost vision from this condition. So what you need to know is if this comes up in the OSCE is urgent steroids, like even if that's not the diagnosis, if you're considering it, give them steroids, figure out what it is later. Don't wait for the biopsy. Tension headache, like we said, is a bilateral non-pulsatile headache, scalp and muscle tenderness, band-like, and your management is stress relief. Cluster headaches, we already spoke about them as well. Males, smokers, we don't have a fucking idea why this happens, but sudden onset pain around one eye, teary, bloodshot eye, and rhinorrhea, so snuffly, and they also can get meiosis and ptosis, like we said, autonomic features. It's always one side, always the same side, short duration of pain, once or twice a day, commonly at night, the same time every day, for a few weeks, for about 1 month, 1 to 3 months for a year, and it happens again in the same 1 to 3 months every year, again and again and again, and it just happens at the exact same time. The management I wouldn't worry about. Migraine, who knows why they happen, but unilateral severe throbbing headaches with nausea, vomiting, photophonophobia. A common migraine is the one without an aura, it's just straight headache. Classical migraine has aura, followed within an hour by the headache, but you can get, like I said, just the aura and no headache. And the classic aura is a visual, so you ask them if you had any visual disturbances, lines, dots, or loss of vision, but it could be literally any neurological symptom as your aura as well. Triggers, the acronym is chocolate. You can have a read of what that is, but I don't necessarily ask all of those, but some of them are quite important. Management of migraine, I think it's a good thing to cram just before an OSCE, just in case. It's very unlikely they'll ask it to you, but always begin your management with lifestyle first. So the first thing is avoid all of these triggers. Some of them obviously are preferable not to avoid, but some things they can. Don't give codeine, whatever you do. Codeine causes rebound headaches, which is worse. During an attack, we recommend lots of different things, and tell them to go see their GP and trial lots of different things. The one new thing that you should probably be aware of is triptans. They're classically used like the wafers or tablets. And then in terms of prevention, not everyone gets a preventative, but if they're getting quite frequent headaches, you can consider. And because we think migraine are vasospasm related, you give things like propanolol. Is one of like the classic first thing to try as a preventer of migraines. All right, next question. 90-year-old woman who tripped and hit her head 3 weeks ago gradually becomes confused. What's the answer here? I hear Jay over there. Does anyone disagree with Jay? Anyone agree with Jay? All right, the answer is definitely Jay. Cool. So subdural hemorrhage, very old, trauma as well, bridging veins, burst, and becoming more and more confused over 3 weeks. So like I said, it's a concave picture. Okay, elderly alcoholics, falls, your classic thing here. Fluctuating consciousness is a bit of a buzzword. Okay, deceleration injury as well. Anyone have any questions so far? No questions? Cool, let's keep going. An obese 37-year-old woman, I think I've already given the answer away, with 6 weeks of increasing headache and visual blurring whenever she bends over. Any answers? The trick here is that the diagnosis might be easy, but the clinical signs require one extra step of thinking. I'll always recommend elimination with EMQs. It's a good way of getting rid of a lot of things. Yeah, I'm hearing F over there. Does anyone have anything different to F? Everyone happy with F? Would everyone put F down? Okay, so yes, the answer is F. So this is idiopathic intracranial hypertension, which is obese woman, headaches and visual symptoms as well. So those are the two classic things. Visual symptoms means where you're getting quite advanced. We're never bending over, so that's increased pressure of the CSF. So that's a classic picture for this. And F is, what's that sign called? Swollen optic discs. Papilloedema. So that's a classic sign of elevated intracranial pressure. So that's what the answer is. So one other thing I would say is these EMQs, Monash tends to have one little stem for each of the options of A, B, C, D, E, F. This is the one that's come up on the Monash EMQ, the one that they've released it. It could very well be that on the day you're going to get the option that was D. So I would make sure to look up all of these signs, every single one of the questions that Monash has given you in those faculty released papers, and try to figure out, oh, what would be the presentation for this, so that you kind of have an idea as well, you know? So I would use these questions to guide your studying quite a bit. That the same ones might actually come up. Okay, so we already spoke about most of these signs of raised intracranial pressure. Also, another important thing is that they get systemically increased systolic blood pressure with a wide pulse pressure, bradycardia, and irregular respiration. That's like Cushing's triad or something like that. Young obese women is, you still have to rule out tumor, but likely idiopathic intracranial hypertension. Otherwise, you're thinking of a space-occupying lesion. Now, abscess still have some infective symptoms, presumably, but you might also be thinking of brain tumor. So, all right, next presentation. 55-year-old man with no prior medical problems has a 1-month history of progressive right hemiparesis. Comes to the ED because of a generalized tonic-clonic seizure. All right, anyone wants to shout out an answer? I thought this might make people think a little more. Sorry? Someone said F. Anyone have a different answer? Would anyone put something else down? Just tell me what you'd put down. This isn't the actual exam. Doesn't matter. Anyone would put something else down, or would everyone have gone with F? Okay, I'm hearing H. Would anyone say anything else? Please just tell me your answer so that I can go through them, because otherwise you're not going to know why that answer was wrong. All right.
I don't know how to rule out J.
Uh-huh. Cool. I wanted someone to say that. Did anyone says anything else they were considering? A lot of people still looking at the answers. 2 people discussing over there. Sorry? Okay. All right. So let me go through the options you guys have, and people tell me if there's any others that you actually would like me to rule out as well. So it's not stroke, because stroke is acute. So stroke does predispose to seizure, but this has been getting progressively worse, unless he's got one of those syndromes that gives you progressive strokes. And you guys don't have to worry about those, unless it's, like you don't get like progressively worse with stroke. You get really bad and then improves a little bit, or might get worse if you get like massive edema or some shit like that. This doesn't sound like stroke, because 1 month history can't be stroke. It's really acute. Okay, so stroke is out. Someone said H, metastatic brain tumor. What would make you think it's metastatic? That's true. But there's nothing in the stem to give away that there was a tumor anywhere else. So this is an EMQ. It's a Monash question. It's not real life. Real life, you find a tumor in someone's brain, you've got to think, could it come from somewhere else? In the Monash question, there's nothing there to suggest. It's not like, has shortness of breath and coughs up blood. Now he has blah, blah, blah. If that had been the case, I would have gone with a metastatic brain tumor. There's nothing to suggest that, so you're concluding too much. Okay, so that's why I wouldn't go with that, even though it's not unreasonable. Now, we said low-grade glioma as well. Not unreasonable as well. But left frontal lobe tumor, F, what was said before, is more specific to the presentation of right hemiparesis. And more importantly, this is 1 month. That's pretty fast for brain tumors. So low-grade glioma would probably not be progressing that fast. I don't know if they give seizures or not. I've never done neurosurgery. I've only done a lot of neurology, but it doesn't sound like it would be this severe. You know, like go from 1 month to hemiparesis and a seizure, it's a pretty fast-growing lesion, in my opinion. So that's why I would put left frontal lobe tumor. Also, it's not guaranteed. It's a tough question, but it's the most likely one because this pathology is in the frontal lobe, and left frontal lobe tumor doesn't impact how fast or slow it will grow. It could be any type of tumor. So I think that's the best answer in this question. Did anyone have any other things that they wanted me to rule out? Don't hesitate to ask me questions, guys. Okay, so you don't need to know much about tumors. What I would think you should know is that raised intracranial pressure should point to a brain tumor. New onset seizures or epilepsy must always rule out brain tumor. Gradually worsening neurological signs without any better alternative cause, so say a stroke, so really sudden onset vascular path risk factors. Worsening neurology, any of these kinds of things, you should be thinking brain tumor. Order a CT and then maybe an MRI as well. CT's first line. Cool. Second OSCE. We're really going to run over time. You're an intern in the emergency department. Your next patient, Willis, has presented after a fit. He's confused and repeatedly asks you to hold the door. List all your differentials. All right. I'm going to stop you guys there. Shout out your differentials. Okay, drugs, yep. Seizure, good. Tumor, is tumor causing a seizure or something else? So this is the thing with seizures presentation. The first thing you need to ask is it a seizure or is it something else? The second question then is, what is the cause of the seizure? So I wouldn't be talking about differentials of the type of seizure yet. You should also be thinking about what you're going to rule out once you turn out as a seizure. But I'm asking the first question is, what are the differentials to this type of presentation? One of them is a seizure, could be from a tumor, could be epilepsy, could be a billion things. What else? So drugs would still be causing a seizure. Anything else that this could actually be? Hypoglycemia, perfect. Anything else? Nothing. Sorry? Vasovagal, so I'm going to put that, yep, let's keep that as a separate category. Anything else? Delirium, would delirium be causing, it could potentially be causing a fit or a faint or something like that. Unlikely, they're not going to be asking you delirium in third year. Delirium is fourth year. Anything else? All right, so with episodes of fits, faints, or funny turns, which is what you ask the patient, people will tell you all sorts of things. They'll tell you, oh, this person had a seizure for half an hour. Really, they were down for 2 seconds and they had one twitch. Because time just stops when something weird happens to people. It's not the collateral history's fault, but people are very bad at describing it to you. So you don't know that it's really a seizure, even if they tell you this person's been twitching and shaking and saying hold the door repeatedly. So what I was taught is brain heart sugars are crazy are the causes of any of these presentations. So brain could be a true seizure from epilepsy, could be epilepsy, could just be a seizure of no cause, could be epilepsy, could be a brain tumor, could be alcohol, drugs, electrolytes affecting the brain, could be hypoglycemia, it could be a heart condition. I'm going to put vasovagal under heart, but really they're quite separate from arrhythmias as well, which is what I was hoping people would say. Cardiac conditions can cause someone to faint. And the patient could just be crazy and having psychogenic non-epileptic seizures. Okay, I don't have anything against that. So with an OSCE approach to a history of seizures, what are the things you want to ask the patient? What is your approach? You know, if the patient comes in, Hodor's there, and you're having to take his history from the seizure, what are you going to ask? Okay, well, yes, presumably someone will say yes to that. What else? Sorry? Absolutely. So always ask for a collateral history. They could actually have two people in the OSCE station. Oral. So yes, was there anything before that preceded it? Any other questions? Sorry? Yeah, so you probably can't ask the patient themselves that unless it was they were completely aware if they didn't lose consciousness. Perfect. Okay, how did you feel afterwards as well? So seizures, you should do, WWQQ. I actually use Socrates. I think it's better, but your choice, practice OSCEs decide. You must ask for a collateral history if there is. Obviously, in the OSCE, you would just say, I would, if there isn't a second person there. But with the fit history, you must clearly identify if they've ever had any previous episodes before of febrile convulsions as a kid. So has this ever happened to you before? Important question, because you can't diagnose epilepsy unless they've had one or more. And if they have a brain tumor sitting there, chances are they might have had, this might not be the first seizure. Then pre-ictal. So you certify it into pre-ictal, ictal, and post-ictal questions. So pre-ictally, were there any triggers? So drugs, alcohol, poor sleep. Do you see lots of funny lights in the TV, anything that caused it? Have you ever had any head injuries before? So strokes and head trauma are risk factors. Many metabolic disturbances, so maybe they've got renal problems, fevers. Then aura, and so auras could be flashing lights if it's a visual aura. It could be, if it's a temporal seizure in particular, you get things like rising butterflies in stomach or sensations of deja vu over familiarity with things. So just ask them, have you had any strange sensations before? Or any unusual smells and tastes. All of these things can be an aura to a seizure, and it kind of reflects where in the brain the seizure is coming from. You don't have to be able to tell that though, not in third year. Then ictal. What did the patient do during the seizure? Did they stare blankly? Did they have any convulsions or jerks? So did they do a tonic and clonic movements? Did they do any lip smacking or chewing, which are called automatisms that you get with temporal seizures in particular? So you need to be very specific with everything they've done. Then a really good thing to ask is, did they bite their tongue? Was there any blood from their mouth? Were they incontinent of urine or feces? If the patient did bite their tongue or was incontinent, is that pointing towards what? True seizure. It's very unlikely that anything else would give you those. Those are pretty good pointers to a true seizure. And then were they conscious during the episode? Was it a complex or a simple seizure? Do they have any memory of it?
So we just treat both types of, like a peripheral tongue bite and a central tongue bite as both being for a seizure.
Sorry?
Like, isn't it a peripheral tongue bite seizure? But if you bite the front of your tongue, it's like not a real seizure.
I don't think Monash will get that specific with you. Okay, don't ask where is the tongue bite, because they're not going to draw that on the sim patient. I mean, if you know that kind of stuff, it doesn't hurt to ask, but it's never going to get to that stage of specificity. No, if you just, they'll just be impressed that you asked about tongue biting. And then post-ictally, how did you feel afterwards? Did you have a headache, a confusion, muscle pain, a sore tongue if you bit your tongue, and any weakness or something like that? So that's called a Todd's paresis, is weakness after a seizure. All of these things are what? Do they point to or from a seizure? All these post-ictal things, do they point towards a true seizure or not? True. Okay, so let's look at this question. 21-year-old man falls unwitnessed to the ground in his kitchen at 7 in the morning. His girlfriend hears a noise and calls to him. When he doesn't respond, she finds him a minute or two later, lying on the ground confused. He gradually returned to a normal mental state. He had been out drinking the night before. What do we think this is? Anyone want to shout out an answer? H, hypoglycemia. Anyone has shown shout out a different answer?
I want to say epilepsy, but don't you need more than one seizure to diagnose epilepsy?
In real life, yes, but this is an EMQ. They're asking for the most likely cause, not which can you diagnose technically. And that's actually not entirely true. You can diagnose epilepsy on one seizure and a high likelihood of another. Does anyone have any other things that they want to put up there? Although I feel like I just gave away the answer anyhow. What I would say is, so this question was debated a lot. The answer is epilepsy. Why? There's a few factors here that put it towards a true seizure. The other things here don't really point to a true seizure. And in particular, even though it's the first seizure, it doesn't just say idiopathic seizure is an option. So epilepsy is your next best thing, because chances are it's going to be an underlying epilepsy syndrome more likely than anything else. So someone said hypoglycemia. Why did someone say hypoglycemia? He's in the kitchen. He's probably eating something as we speak. Oh. Well, it wouldn't get that badly that quickly that you could get to the kitchen, start preparing a sandwich, and then fall unconscious. Hypoglycemia, they get progressively worse. It doesn't just go perfectly fine then seizure. So that would be the first thing. The second is we don't have enough reason to really believe you'd be hypoglycemic. And the other one is that a lot of the things point to a true seizure. Also, if it was hypoglycemic, you need glucose to get better. And no one said that he's had anything here to make him get better. So I agree. Look, a lot of people thought it was hypoglycemia. It is epilepsy. Does anyone want to point to me the factors that make them think it's epilepsy or at least a true seizure? It's not a great question. A real epilepsy, you would have 2 seizures, but age, perfect. A really classic age to develop an epilepsy syndrome. Other points?
Non-responsive for a period of time.
Non-responsive, so gradual return to a normal mental state is classic of seizure. Yep, absolutely. Anything else? Yeah, alcohol is a trigger. Yes, sure, it could cause seizures on its own, but he's already woken up the next morning. It's more of a trigger to epilepsy at this stage. Any other things? Anyone have any? There's one more thing here that I want someone to say. Yes, so there's an epileptic cry or a groan or something like that does exist. It's a bit of, like in reality, you're not going to hear it that much, but it does definitely point to a true seizure as well. So yes, that is one of them as well. Okay, so also the duration, a minute or 2 later, sounds like a seizure as well. Okay, so all in all, it points to a seizure because there's just no better alternative here as well. It's not a brilliant question, but it is epilepsy. So I constructed this table here, which is basically what we've just talked about. I think it's very important to know the things that favors seizures or favors other stuff. Okay, so a slow recovery, confusion, weakness, and residual neurological. So a Todd's paresis still weak after the seizure, favors seizure, a true neurological thing. Favors something else is if they recover immediately. That's classic of arrhythmias. Okay, so pale or red is also a classic of arrhythmias, whereas cyanosis is more likely a seizure from not breathing that well. The epileptic cry, which is what we just spoke about, if they describe really good seizure movements the entire time, that is good, but that's not enough. You can have a faint, a vasovagal, and still do a bit of twitching. They'll show you that video if you're at MMC in the lectures later of these German medical students who hold their breath for a certain amount of time and then they all faint and have a seizure, and it's just a faint. It's not a true seizure. So it's important to keep that in mind. Tonic-clonic jerks aren't specific for seizure, but they do point in that direction. Incontinence and tongue biting are really good. An aura as well makes it quite likely. A fit while asleep and lying down, it's unlikely to have been anything else. And alcohol, low sleep are good triggers as well. So you need to always have these factors in mind. And that's why when you're doing a seizure history, it's important to take a collateral and ask about the pre-ictal. What happened before? Were there any triggers? Do you have any predisposing brain damage? What happened during the seizure in specifics? Any automatisms, any movements? Were you conscious or were you not conscious? And then lastly, how did you feel after the seizure? Were you confused? Was there anything like that? Oh, and also during incontinence and tongue biting and any noises or anything like that. Any questions so far? So this is an OSCE that they could throw. Okay, so classifying seizure types. I have the old classification here. I do not have the new because the new is confusing and you don't have to know it. Okay, so just focus on the classic. Even though neurologists will confuse you in a neurorotation, just focus on your classic classification of a seizure. So simple partial is where there's a focal symptom, so either motor, so one arm, sensation somewhere, autonomic, but the patient is aware the entire time. A complex partial has focal neurological features, but awareness is impaired. Usually points to temporal lobe that awareness is impaired. A partial seizure with secondary generalization is when it becomes a convulsive generalized tonic-clonic seizure after it started off as partial. Generalized seizures are tonic-clonic, which is known as the grand mal, which is the classic tonic and then clonic seizure with post-ictal confusion and drowsiness. Absence seizures is PED, so don't worry about. Myoclonic seizures is a sudden jerk of like one limb or a torso or something like that. Don't worry about them, just know the name. So we kind of already gave this away, but you always have to look for, so the second question after you've decided it's a true seizure is, why the hell did this patient have a seizure? So you must look for a cause. And if none, it could just be a random one-off seizure or first presentation of epilepsy. Any questions so far? Okay, so how do we diagnose epilepsy? I think I already spoke about it before, so I'm not going to make anyone answer.
Classically, at least 2 unprovoked seizures occurring 24 hours apart. So if you took ice before each of them, it doesn't count. Okay, they have to be unprovoked. There are other criteria as well, like an epilepsy syndrome or high risk of another seizure, but we don't have to worry about those. So I'm not going to give you 30 seconds because we have like 20 minutes left. But I want people to shout out the investigations that they would like to order for a patient presenting with the first seizure. Someone?
Yes.
Perfect. Good bedside test. Any other bedside tests? ECG. Great. It could be an arrhythmia, so don't forget the ECG in the bedside. BSL, ECG in the bedside. Okay. Urines? Why the hell not? Give them a dipstick. Okay. What blood tests? Sorry? Yeah. LFT, CRP. Yep, for everyone. What else? Yep, so UEC is electrolytes, but also I would check on CMP as well, so calcium, magnesium, phosphate. So do the full stack of them. Great, so electrolytes, what else? Any other investigations you want to do if a patient came in with a seizure? Just let them go home? You don't let them go home? Would anyone like to say something else? Straight away? $400 MRI as soon as the patient comes in with a single seizure? Sure, Cabrini maybe. CT brain, possibly. It might reveal a tumor. So I would consider imaging, not necessarily at first presentation, but if you're private, yeah, sure, go MRI. But in an OSCE, I would say I would consider down the line a CT brain or MRI. If they have risk factors for brain, if you're thinking brain tumor, you might think of, yep, a CT brain as well. And one other test that I want someone to say. It's a classic test for seizures. EEG. Sorry? What did you say? I don't know what that is. EEG, yes. So glucose, dipstick, yep, we said all of those. You could do you should do a CT on presentation to rule out something serious going on, and probably an outpatient MRI. ECG, like we said, for arrhythmia. EEG is a test for seizures. Now, no, you don't have to know anything about EEGs other than 3 Hertz spikes on an EEG equals absent seizures, because that could come up. It's a buzzword. But what you should know is that an EEG is just a test that you do for a seizure. Now, most people, when they come in, it's already past the seizure. It's pretty useless. It might pick up some classic discharges or some abnormalities, so you still do it. Chances are it will be useless. But there's a thing called video EEG monitoring that you might have seen on the ward, where they keep the patient in, like sleep deprive them to stress them into a seizure. It sounds pretty horrible. They actually do it to capture the waves of a seizure to see whether it's a true seizure or psychogenic non-epileptic seizure, which is a psych problem where they have like exorcism type seizures that don't look anything like real seizures. So management of seizures is complex. I don't want you to worry too much about that. If a cause is found, treat the cause. So if there is a brain tumor on the CT and MRI, you would consider surgery. Who knows if you would or wouldn't do it, depends on the location, lots of things. But basically with seizure management, 2/3 chance of a single seizure will just be a one-off. So you only give anti-epileptic treatments for someone with epilepsy or someone with a 1 seizure and a stroke or a brain tumor, so they have a pretty high likelihood that it's going to come back. There's a reason for them having a seizure. Acute treatment. So if a patient comes in with an ongoing seizure, in particular what we call status epilepticus, does anyone know how to define status epilepticus? Sorry? Someone said something over there. I think it was correct.
More than 5.
Yeah, okay, so more than 5 minutes you treat. In reality, it's more than half an hour, but you're not going to let someone seizure away for half an hour. So yeah, you'd be treating that. So IV benzodiazepines, diazepam, and if that doesn't work, you go to phenytoin or levetiracetam. Don't worry too much about that. You should just know that you should treat a seizure if it's acutely. They're still seizing acutely. Anti-epileptic medications, just know 1 for each type of seizure. So for focal, carbamazepine. Generalized, valproate. And Keppra of levetiracetam is one you'll be seeing everywhere, but don't worry about that in your OSCE. Just you're going to see it on your neurology rotations. Just random points about seizures that don't fit anywhere else. So Southeast Asian who takes carbamazepine and they get a terrible rash has Stephen Johnson syndrome. For Vic Roads, 6 months seizure-free before they're back on the license, but double check this, they change it. Something that they do like to ask with OCMED, so make sure you actually remember the answer to this question. And the seizure and fever in an adult is meningoencephalitis until proven otherwise, so you actually start acyclovir straight away and then worry about LPs and stuff like that. You're not going to get this on the exam. So like I said, the summary of a seizure, OSCE, the things you need to be thinking of is, first of all, rule in or out. Is it truly a seizure? Then what type of seizure? Is there a cause? So do your test for brain tumors, check if there's a stroke or anything like that. Does it classify as epilepsy? And is some form of treatment required? You're not going to be asked to do anything too in depth. No more depth than what I've spoken about. Okay. Now, I still have like 100 slides, 200 slides to go. And not that long, so we'll just whiz through. I'll probably focus on the questions more than anything else. So a 45-year-old known diabetic patient presented with acute onset of shaking of his left hand when he tried to use it, and unsteadiness of gait of 2 days duration. The examination shows dysarthric speech. He's got difficulty performing finger-to-nose testing on the left, but was normal on the right, and ataxic gait. What are your answers? What is this tremor? Shout it out. Anyone have anything other than cerebellar tremor here? Because I want to rule out if you did get it confused. Everyone happy? Everyone would have put cerebellar? Sorry? No? So what? Can someone tell me what they would have put? Anyone have any alternatives? Because I'm getting some shaking, but no one's telling me anything else.
I was just wondering how patient being diabetic is related.
Okay, so what's diabetes a risk factor for? Everything. What specifically would affect a brain or a cerebellum? Stroke. Did someone say stroke? Yep. So look, it's a weak link. You probably didn't need that in the question. What I would say is some of these things, don't worry too much about them. Like it could be a red herring in the question or something not that important. It just fits cerebellum all that well that it can't be anything else. The diabetic here means that she had a stroke, because like 45-year-olds don't usually get strokes, but if they're overweight or diabetic, they might. So probably got a cerebellar stroke. So why is this? Why is this cerebellar tremor? The first thing is shaking of his left hand when he tried to use it. That rules out Parkinsonian tremor. Parkinsonian tremor is a pill-rolling resting tremor. It happens at rest. On movement, you have essential tremor, which is a disease of itself. You also have cerebellar tremor or intentional tremor. Why am I doing this? Because cerebellar tremor isn't really a tremor. It's not. It's you go and you miss the target and you go back and forth. It's not a tremor. A tremor is the same oscillation back and forth. Annoys me a little bit. But that's what the answer was looking for. Cerebellar tremor is the answer here. Why? Try to use it, so it's intentional tremor. Unsteadiness of gait, what's that called? What's the neurology term for unsteadiness of gait here? Ataxia. Yep. So he's got ataxia. Dysarthric speech. What causes dysarthric speech? What's the answer to the question? Cerebellum can cause staccato speech, so you actually get speech problems as well, because the cerebellum controls all motor function, including speech. Difficulty performing finger-to-nose test. Now, that's a specific cerebellar test, okay? But was normal on the right, so it's obviously unilateral cerebellar stroke, fitting in with the diabetic picture, because it's saying that it's only one side of his body, so only one of his 2 cerebellar lobes was affected. And they even say his gait was ataxic, just to confirm that that was the word I was looking for. I didn't even notice that that was there. So it is cerebellum, and like we said, the cause is a stroke. So let's go on to cerebellar disease. I'm not going to make you guys write this all down. Shout out symptoms of cerebellar. Symptoms or signs of cerebellar issues. Sorry? Yeah, what does that mean? You can't ask the patient, you have this diadochokinesis. Yeah, you can't do that. Difficulty with rapidly alternating movement. So you see they'll just fuck it up completely. Any other symptoms of cerebellar disease? Yep, what does that mean?
Can't like complete a shape well, you overshoot or undershoot.
Yep, okay, yep. Not really going to find out anyone testing that all that often, but yes. They do the test where you make them point towards the ballistic tracking. Any others? Nystagmus, yes, absolutely. Anything else? Wide-based, sorry, shuffling is more Parkinson's, but yeah, wide-based gait, could be shuffling. But broad-based gait is what you'd be seeing. Anything else? So the acronym I use is VANISHED. It's got every single thing there. You guys got most of them, but vertigo as well, ataxia, the intention tremor, the slurred speech, which is dysarthria. How does dysarthria and dysphasia, how are they different, by the way? It said dysarthric speech before. Neurologists love asking this question. What's the difference between dysarthria and dysphasia? Anyone know? What is dysphasia? A little more specifically. I don't think that was any more specific. Okay, dysphasia is difficulty with the generating of words. So if it's in the expressive Wernicke's aphasia or dysphasia, you can't understand the meaning behind the word. If it's Broca's, you can't generate the thought of the word. Dysarthria is difficulty with articulation. So you're intact in understanding and producing speech over here, but the difficulty is actually getting the word out. That's what dysarthria is. So cerebellar sign, they can understand the speech quite well, but they sound like they're having trouble getting the words out. Okay, so it's a more motor, lower motor type problem. That's what dysarthria is. Okay, so yep, so that's everything else like that. Don't have to regurgitate all of those, but I would recommend knowing your cerebellar signs because they asked a lot of neuroanatomy questions last year, which is what my slide says. So there were literally questions just about neuroanatomy. Where is the stroke? Was a whole stack of questions. So I would focus on knowing that. So what are your differentials for cerebellar disease? Because of time, I'm just gonna go through. So cerebellar things that cause cerebellar disease are stroke, brain tumors, multiple sclerosis, a few other things as well, but these are basically the ones you need to be thinking about. Okay, so how can you tell apart causes of cerebellar symptoms? So if Charlie's a 60-year-old obese janitor who smokes, what's that going to be? Yep, that sounds like a guy who's going to get a stroke. If Charlie has recently had worsening balance and has papilloedema on examination, yep, that sounds like a tumor. Increased intracranial pressure, probably a tumor around the cerebellar area as opposed to a tumor somewhere else. Charlie is a 25-year-old female who also recalls some vision troubles last year. MS, exactly, okay? So EMQs will make it pretty obvious, okay? So I'll leave that all for you guys to read, but it's a lot about the onset, how gradual, sudden, episodic, and the age and risk factors of the patient. Yeah, we have a lot to get through still.
You can go 15 minutes over time.
Okay, cool. All right, well, anyone can leave after 8. I won't get too offended. Okay, so we'll go over a little bit. Okay, so like I said, ophthalmology isn't going to get examined this year. So vision complaint, but I'm going to go straight to vision now. Could be either vision loss or double vision. What's the difference between vision loss and double vision? Why am I making a big deal out of them? In terms of the cause. Yep, specifically, vision loss is sensory. Double vision means a motor problem always. So vision loss, let's go through where the symptom is. So if Arya can't see peripherally on both sides, what's causing this? Yep, everyone got that? Bitemporal hemianopia, a pituitary tumor pressing on the optic chiasm causes bitemporal hemianopia. You lose the crossing over fibers. We'll go through the visual pathway very soon. If Arya's got poor vision on her left eye, but the right eye is completely fine, what does that sound like? Where's the problem? Just tell me where the problem is if her left eye can't see, but the right eye is completely fine. Yes, or her left eye, exactly. So because this is third year and it's not going to be the eye itself, we're going to go with left optic neuritis here. And Arya can't see things on her right side. Sorry? Yep, all the way to the occipital lobe. So anything before that. So this is an important description, an important distinction rather. So bitemporal hemianopia is always optic chiasm. If it's one eye, it's before the thalamus. So the optic nerve already higher, or the eye itself. Whereas homonymous hemianopia, whole side of your vision missing, means the occipital lobe or the tract going over there. So The causes, like we said, pituitary tumor usually causes the bitemporal hemianopia, usually pituitary adenoma. Multiple sclerosis is your classic cause of optic neuritis. And stroke is your classic cause of lobe problems, homonymous hemianopia. So I would make sure you know these pathways really well. It's second year stuff. I was going to go through it today, but I don't think I have time. There's more important things. One thing to mention, quadrantinopias. Well, everyone knows hemianopias, but not quadrantinopias. With quadrantinopias, it's just one step forward. So the pathways here, they go through two different lobes. So one pathway goes through the higher lobe, the parietal. One goes lower through the temporal lobe, okay? Everything in the brain is the opposite. So not only is everything on the right coming from your left side of vision, but everything that's above is coming from below and vice versa. Does that make sense to everyone? So if it's parietal, it's the vision that came from underneath because it's all opposite. If it's your temporal, it's the vision that came from above. So if the patient has a left temporal lesion, what type of quadrantinopia are you going to get? Anyone? Was that too fast? I lost everyone. Everyone's already too tired and late on the Monday. Sorry? Right upper quadrant. Yeah, right parietal is another part of the brain. Exactly. So left temporal lesion is left, so it's the right right side of the vision. But if it's in the temporal lobe, that's lower down, so it's the opposite. It's going to be your right side of your vision. So that's how quadrantinopias work. So left temporal would give you a right upper quadrant vision. Right temporal would be left upper quadrant quadrantinopia, and vice versa. Left parietal, right lower quadrant, and so on. Does that make sense to everyone? They could ask you this. Now, pupil reflexes are both the second and third cranial nerves, sensory or motor. So for each of the following, tell me where the lesion is. So if the light is shined into the right eye, okay, so I'm examining someone, I shine a light onto their right eye, but only the left eye constricts. Anyone want to tell me what the problem is? Yeah, of which side? Okay, so I'm hearing some muttering of right efferent. Okay, so what happens is when you shine a light, if the optic nerve is intact, it will take that back to the brainstem. It will then send the both oculomotor nerves to constrict the pupils. If you shine a light into the right eye, but only the left eye constricts, it means the message got there, but nothing came back to the right eye. So it's the right oculomotor that's screwed up. If the light is shined into the right eye, and only the right eye constricts, where's the problem? Yep, I heard third left. Is everyone here happy with third left? Okay, it goes there, but only the right gets the message back. If the light is shined into the right eye, but neither eye constricts, where's the problem? Sorry? Yep, perfect. Okay, so just shine it out so we go faster. Cool. A 22-year-old female university student with 1 week of blurred vision and difficulty discriminating colors, as well as pain on eye movement. What are you going to find on her examination? Anyone want to tell me what their answers are? Hands up if you think it's A, clockwise torsional nystagmus. B, fatigable ptosis. What does fatigable ptosis mean, by the way? What disease? Myasthenia gravis 100% of the time, all the time. Okay, relative afferent pupillary defect. Hands up if you think that's the answer. Okay, a couple of hands up. Leading eye nystagmus on left lateral gaze. One hand up. What is this called, by the way? If you put your hands up, you probably know what this is, no? This is hinting at internuclear ophthalmoplegia, which we'll go through. Left-sided ptosis, hands up if you think that's the answer. And swollen optic discs. Hint, that was already an answer. It's not going to come up twice. So the majority of people, and by that I mean like 3, put C as the answer, which is the right answer. Okay? This is not necessarily that easy because you don't get taught what a relative afferent pupillary defect is. Okay, now when you do the pupil reflexes, you shine light on the eye twice to look for a direct and a consensual response on both that eye and the opposite. Same on the other eye. Then you do a swinging light test. Okay, hands up if you would do a swinging light test in your cranial nerve exam. Hands up if you know why. Cool. No one explains this to you. The swinging light test goes from one eye to the other, looking for this thing called a relative afferent pupillary defect, which is the answer here. What is that? That happens when the optic nerves are not completely gone. One optic nerve is okay. The other one's like, let's say 85% screwed up. It still takes vision. So when you shine light onto that eye, let's say it's the right eye, you shine light onto that eye, and then what happens is they constrict. But if you go from one eye to the other, because this eye is like 85% fucked, this eye is perfectly fine, you go to that eye, lots of light, both of them constrict quickly. You go to that eye, it's pretty crap. They start dilating really slowly because it's less light than you saw before. Then you go to that eye, they constrict again. That eye, up, and they keep going like that. That's called a relative afferent pupillary defect, meaning that relatively there's an afferent defect. It's not a perfect afferent defect. There is constriction, but relative to the other eye, one eye is really crap. That indicates either optic neuritis, so inflammation, or ischemia of one of the eye nerve, one of the optic nerves, when it's still kind of okay, but just not that good. Okay, so this is exactly what would cause 1 week of blurred vision and difficulty discriminating colors, and pain is classic of optic neuritis. Optic neuritis is painful. It causes color problems and blurry vision of one eye, and it would classically give you, if it only affects one eye, a relative afferent pupillary defect. The optic disc can be completely normal on ophthalmoscopy. So does that make sense to everyone, or did I confuse the crap out of the audience? Okay, so that's what I was talking about. Optic neuritis, ischemic optic neuropathy are the causes of that. And optic neuritis is classic of multiple sclerosis' first presentation. Would a cortically blind patient have abnormal pupillary reflexes? So a patient who's blind and who's got both occipital lobes chopped by a hammer, I don't know. And would their pupil reflexes be normal or abnormal? Someone shout out an answer.
No.
Sorry?
No.
I said normal or abnormal. What does no mean?
No, they wouldn't have abnormal. They would have normal.
Okay, great. Why? Because the reflexes are mediated with a brainstem. Okay, I asked a bad question, whatever. Big deal. Brainstem mediates it. So the cortex isn't responsible for this. This goes directly from second to the third nerve. It's a reflex. It doesn't involve the cortex. So they have normal pupillary reflexes. Now, what's an Argyll-Robertson pupil? That's a buzzword. Anyone tell me what an Argyll-Robertson pupil is? Has anyone even heard of this?
So it's in, I think, diabetic retinopathy and in neurosyphilis. Essentially, they can accommodate, but they can't constrict with light.
Mm-hmm. Perfect. That's exactly what an Argyll-Robertson pupil is. Hard to remember, but it is a buzzword. So the way I remember it is you think of a prostitute because they have syphilis, and the prostitute accommodates, but it doesn't react. Okay, just like the pupil. I didn't come up with this myself. Someone, a final year, taught it to me last year. It's a great way of remembering it. Say what you will. So the eye constricts. It accommodates when looking here, but it doesn't react to light. Okay, that's an Argyll-Robertson pupil caused by syphilis, also diabetic retinopathy. Okay, all right. A patient complains of double vision when looking to the right. On examination, you notice that when he attempts to follow your finger to the right eye gets nystagmus, and the left eye doesn't go any further than midline. Accommodation is completely normal. What's this called? So they're looking to the right eye goes, but it has nystagmus. The left eye stays in the middle. Doesn't go all the way to the right. Anyone know what this type of thing is called? You can cheat by looking at the next slides. I'm going to keep doing these weird hand motions until someone says something, so please answer. It's not 1.5 syndrome. It's half of 1.5 syndrome. You don't need to know about 1.5 syndrome. What's this called? Anyone heard of internuclear ophthalmoplegia? Okay, internuclear ophthalmoplegia is caused by damage to the medial longitudinal fasciculus. Now, it sounds like I'm just making up words right now. It most likely indicates multiple sclerosis. So let's go through what this is. Okay, this patient decides to look to the right, to one side, and it's normal. So that's the, I'm just pointing to myself here. This side, it's normal when they look to one side. They look to the other side. So this is the left internuclear ophthalmoplegia. The left eye has nystagmus. The right eye doesn't go any further than midline. What the fuck is going on? Basically, internuclear means in between the nuclei. Which nuclei? In between the nuclei of the sixth nerve, the one that abducts the eye away from midline, and the third nerve, which adducts the eye towards the midline. So in this case, if you take the left nucleus of the sixth nerve nucleus in the left, it tells the eye to go all the way out. And the message comes from there. The medial longitudinal fasciculus is a bundle that goes up to the third nerve and says, hey, I'm going all the way to the left, follow me. So the leading eye is always the one abducting. So if it's to the left, it goes out, then it says to this guy, come and follow me, and your eyes move together, conjugate eye movements. If the medial longitudinal fasciculus is fucked, this eye can't go any further than the midline because it doesn't get the impulse from the other eye saying, come to this side. So it stays there, and then this eye goes all the way to the side, and it's like, wait a minute, I'm getting double vision, so it gets nystagmus as a corrective response. So the nystagmus eye is perfectly normal. It's the eye that's not going to the midline that's causing this problem. Why is this important? It's a buzzword, okay? Internuclear ophthalmoplegia is a buzzword. So internuclear, in between the nuclei, in between, in this case, the sixth and the third cranial nerve nuclei, caused by damage to the medial longitudinal fasciculus from one side to the other. It runs like that. And if it's a lesion of the left medial longitudinal fasciculus, it causes a left INO, that is difficulty of the right eye moving left. I hope I haven't confused the crap out of everyone. And this is classic of multiple sclerosis. It can also occur with the brainstem stroke. Bilateral internuclear ophthalmoplegia, where it happens with both sides, is pathognomonic of multiple sclerosis. All right, let's move on. I'm sure I confused everyone for a Monday very late. You're welcome to leave, like if the lecture is meant to be over, but I'm just going to keep rambling. A 55-year-old presents with a neck nodule and left-sided total ophthalmoplegia and absent corneal reflexes. What's causing this? Hint, it's got to do with the thyroid. Sorry? Someone shout out an answer? Someone said B? Would anyone put anything else other than B? So Graves' disease causes Graves' thyroid eye disease, or Graves' eye disease or thyroid eye disease. Classically, it causes swelling in the orbit, and all sorts of eye movement problems can occur from thyroid eye disease. I'm not going to go through this. You should know your palsies of each of the three nuclei. So oculomotor causes down and out eye. Trochlear is the one, fourth nerve is the one that causes difficulty climbing stairs, and the patient has a head tilt. And abducens is it just can't abduct. It's that simple. Okay, this question. For a 6-year-old woman with 6 months of intermittent double vision and drooping of the right upper eyelid, which is worse in the evenings, what causes this? Or what would you expect that on the history? On examination, rather. Anyone has an answer? Sorry? B? Yep, did anyone get anything other than B? Anyone has no idea why B is the answer? Sorry?
When does A happen again?
That's usually a central pathology, so stroke, things like that, cause torsional nystagmus. Don't quote me on that, though. Yeah, don't quote me on that, though. I do forget that. But yeah, fatigable ptosis. Fatigable is a buzzword for myasthenia gravis. Okay, how do you examine fatigable ptosis? Literally, you get the patient to look up for as long as you can. And if their eye starts drooping, if their eyelid starts drooping, they've got fatigable ptosis. It just can't hold on for that long. So you just keep doing that. Now you can ask, you could just keep your finger there for an hour. Surely they're eventually going to get fatigued. So the answer is, if your finger gets tired before their eye, then they don't have myasthenia. So it's a buzzword, fatigue. Things worse in the evening is buzzwords as well for myasthenia. Myasthenia basically can cause, we'll go through, fuck that. Okay, third nerve, I'll go through myasthenia in a second. I probably won't. What are two common causes of an oculomotor nerve palsy? This you see a lot in the ward. Anyone want to shout out why you might have a third nerve palsy? Sorry? Yeah, raised intracranial pressure. Classically, by itself, it causes a sixth, but different cause inside the brain, a space ocular annihilation, could compress that. Any specific things that classic of third nerve palsy? Anyone? All right, no one's paying attention, so I'm just going to keep going. Diabetic neuropathy or compression. So posterior communicating artery aneurysm classically compresses the third nerve, and that's a worrying thing. And then diabetic neuropathy causes a mononeuropathy of the third nerve as well. And that is, one of them is really dangerous, having a massive aneurysm inside your brain. The other one is pretty benign, the diabetes. As in, diabetes is bad, but yeah. But how do you tell them apart? The parasympathetic fibers run on the outside of the third nerve. So if the pupil isn't spared, so if there's pupil problems in the third nerve, that means it's being compressed extrinsically. If it's a diabetic microinfarction, that means it's the intrinsic problem. So there'll be sparing of the pupil. It will only be the eye movement and lid problems. It won't cause pupil problems. Okay, you can look at all of this later in your own time. Okay, differences between upper and lower motor neuron lesions. This is really important. Can people just shout out? Sorry?
Everything goes up in upper motor neuron lesions. Hypertonia, hyperreflexia, Babinski goes up.
Cool, quite a few. The opposites are true in lower motor. I'll just go through these quickly. I think it's very important to know all of these because they do come up. They can come up. So hypertonia in up, hypotonia in lower, clonus, hyperreflexia, Babinski, and normal muscle bulk in up, and the up. You can read what it says there. I don't need me to read this out loud. Okay. Well, it's almost 8:15. What do people want? Just go through the questions and screw everything else up and forget everything else, or go through specific diseases? Anyone have any preferences?
Questions.
All right, cool. So read up on myasthenia gravis, what I've got there. Okay, Nathan's a 60-year-old male who has been smoking a pack a day since he was 6. Wow, okay. I wrote this like really late. He presents a generalized weakness, particularly with difficulty walking upstairs. He finds that after he exercises, he generally feels better. What the fuck is this? Anyone heard of what this is? Yeah, so this is a buzzword. It's very similar to Lambertitan, except it's the opposite. It's worse. It's better after exercise. It's caused by lung cancer, and it's a paraneoplastic syndrome, which is just like myasthenia with that exception. So this is lung cancer causing Lambertitan syndrome. Just remember it. Okay, Nathan's a shitty intern at a rural. I really picked on him. At a rural hospital, sees a 45-year-old man who complains that his gait has been getting worse lately. On examination, he gets hyperreflexia and hypertonia, but fails to see obvious fasciculations in the patient's hands. What does this patient have? Anyone? Just shout it out so we can go through more questions. Perfect. Okay, so hyperreflexia and hypertonia are what? Upper. Fasciculations are what? Lower. Unless like the patient had a stroke and like broke their arm, nothing causes, single disease causes upper and lower signs other than motor neuron disease. Motor neuron disease has 5 types. ALS is the commonest, and that one causes both upper and lower. The other types can cause one or the other, or pseudobulbar or bulbar palsy. Those are other things. What you should know is upper and lower signs automatically equals motor neuron disease. Okay. You guys happy for me to just keep going with the questions? It'll only take like 5 minutes or more. 25-year-old woman complains of a 3-day history of right-sided weakness. 4 years ago, she had subacute impairment of vision in the left eye that cleared up over 3 weeks. What? Who said MS? Good job. Okay, why is this MS? Why is this nothing else? Can anyone have anything else that they would have considered this to be? Okay, so yes, episodic. Very few things are episodic, particularly like you won't get recurrent strokes in a 25-year-old woman. Okay, so it's the right demographic, right types of symptoms, vision. So the classic first symptoms of MS is optic neuritis, internuclear ophthalmoplegia, or spastic paraparesis, so leg weakness as well. Those are usually the first things. So weakness, and eye impairments, 2 episodes, it's multiple sclerosis. You need 2 episodes, 2 presentations to diagnose MS. Okay. I could go on for like hours on multiple sclerosis. You should know that interferons is one of the treatments, and they do ask this, so it's not really, but for your exams, it's an autoimmune and or inflammatory demyelination and axonal degeneration as well. And there's lots of different phenotypes with relapses and progression of disease. All right, a 60-year-old lady presents with resting hand tremor over the last year. It started initially on the right. Recently, the left side's been getting involved. Her examination shows mild rigidity of both arms. Her gait is slow. Okay, perfect. D. Anyone disagrees that this is D? You disagree? I asked if you disagree. You need to pay more attention, Charlie. Okay. Look, this is definitely Parkinson's. Why? Parkinson's is asymmetric. If you had the exact same tremor on both hands, you actually would think it's not Parkinson's. Examination shows mild rigidity. Now, rigidity and spasticity are different. Why? You will not be able to tell that on examination. I can't tell that on examination. But if you tell a consultant it's rigid, you mean Parkinson's. If you tell them it's a spastic, you mean upper motor neuron lesion. So be very careful with the words you use, because rigid equals Parkinson's. It's one of those things. It doesn't make that much sense, but it just is. And slow gait, so that's the triad of Parkinson's: bradykinesia, tremor, and rigidity. Cool. Don't get too much on Parkinson's. All right, cool. I could go on hours for stroke, but blah, blah, blah. That. Okay, stroke presentations in basic neuroanatomy is very important, so let's just go through this. So Charlie struggles with telling left and right apart, counting and writing. You asked him to show his index finger, but he puts up the middle finger instead. Okay, thanks. Any takers as to where the damage is? Be more general. More general. Yeah. A little more specific. A little more. Yes. That's actually, I mean, I'm not allowed to tell you past questions. So I'm just gonna stop there. That's how much you actually need to know. Is like, it's in the cortex, and the cortex involves thinking. So everything cognitive is usually cortex. This is specifically Gerstmann syndrome of, as you said, dominant parietal lobe damage with MCA. So great to know that. I wouldn't even have told you it's angular gyrus, and I've done a BMed-Sci neurology. So good on you for that, but you don't need to know that for the exams. Keep focus on the important things. If you know that much detail on one thing, and you try to know that much detail on everything, you're just gonna panic. So most important is cortex, but this is specific features of dominant parietal. All right, Charlie complains of numbness on the right side of his face, and left side of his body. On examinations, he's got evidence of Horner syndrome on the right side and a right intention tremor. What am I getting at? Where is this stroke? And what is Horner? Can anyone actually tell me what Horner syndrome is first? Horner syndrome, someone just please say it. Cool. Ptosis, meiosis, and anhydrosis. What does that mean? Sympathetic damage. The sympathetic tract isn't working on one side of the face. Okay, so it's ptosis, eyelid droops, meiosis, pupil constricts, and anhydrosis, you don't sweat. There's no sympathetic innervation to one side of the face. That's Horner syndrome. Where's this lesion, though? Who said that? Good job. Okay, so what's this called? This is Wallenberg syndrome, Wallenberg syndrome, or lateral medullary syndrome. All you need to know is brainstem. Okay, you need to know that this is a brainstem pathology. If you know it's lateral medulla, fantastic. Okay, because of the, and I would recommend revising the side structures beginning with S and the brainstem rules of 4. It's a good way of memorizing this. But basically, you've got the spinothalamic tracts of the face and the body. The face is ipsilateral. That's why you've got one side of the face with spinothalamic damage, and then the other opposite side of the body. Crossed signs always means brainstem. Okay? The other thing is the sympathetic runs on the side as well, so sympathetic stroke would cause the Horner syndrome, and the intention tremor is the spinocerebellar pathway. So those are the 4 side structures within this that are infarcted in the lateral medullary syndrome, but really you just need to be able to tell that this is brainstem. Crossed signs equals brainstem. Memorize that. Okay, can I keep going or should I stop? All right, people just walk out if you're bored, which you probably all are. Charlie suddenly develops severe weakness and numbness of his left leg. Left arm is a little weak. His left face is a little droopy. He also feels very little initiative about life after this event, which is called abulia. Where is this lesion? Anyone want to tell me where this lesion is? Forget the second part. Just left leg, numbness and weakness. Sorry? Yeah, all you really needed to say was cortex. Yeah, so this is an ACA stroke. So I would recommend getting to know that a bit better. Charlie can't see people walking on his right side. What's this called? What's this lesion? Sorry? No, that would be on his right eye, not his right side. Big distinction. Yep, cortex, great. What is this called? It's a homonymous hemianopia, yep. So occipital lobe. And obviously this is, if it's his right side, it's the left occipital. Okay. Just for people leaving, feel free to message me about any questions on the slides. I'll put the finalized versions up after as well. Charlie can't feel pain or temperature in his left leg. His right leg is paralyzed and unable to feel vibration or proprioception. Anyone want to tell me where this is? Brainstem? Yeah, but it's only his legs. I guess the mixed signs rule isn't always true. Did someone say something else? Yep, spinal cord. Why? Because the spinothalamic decussates immediately above, whereas dorsal column and motor tracts decussate at the medulla. So they'll be giving different sides of damage. That's why you get that. This is called Brown-Séquard syndrome. So this is damage at the spinal cord. That's how much you need to know. Okay, left-sided weakness and numbness, predominantly our arms and legs. And this, what's this called, as if you can see from the picture he drew? Sorry? What are you guys saying? Yeah, parietal cortex, because he has neglect. Okay, and it's left-sided weakness. So, yep, so frontal and parietal, so it'd be a right MCA. So memorize you should know your stroke vascular syndromes. It's kind of what I'm getting at here. Okay, what does this sound like? Sorry? Someone said cerebellum? Yep. Cool. Difficulty talking, can understand commands, but can't produce any sentences. Yep. Liberal MP having trouble talking, speaking fluent garbage, says many words that mean nothing and doesn't understand the questions when he's asked. What is this? Wernicke's or a premorbid condition in this particular case. So receptive aphasia. Okay, I'm not going to talk about that, or that, or that, or that. Memorize all of that. Cool, and this is just my way of telling apart different causes. You're not really going to have to do this too much, but I just put it all in a table, so look at it in your own time. Oh yeah, causes of sensory peripheral neuropathies, you should know. They did ask that in an OSCE 2 years ago. So I'd memorize that list. Okay, blah, blah, blah. Off. Oh yeah, Rene and Weber, they asked us about this last year. So I should just point out, you should know your Rene and Weber's test. So Weber's localizes to the right ear and a positive Rene on both ears. What is this? Anyone? Anyone want to tell me what's wrong with this person's ears? Okay, left sensory neural hearing loss, it is. Okay, so remember, you have to memorize how this works. So Weber's, so if both Rene's is positive, that means that air conduction is better than bone conduction, so there's no conductive hearing loss. But then if the Weber's localizes to the right ear, it means that the right ear is better than the left, so the left must have a sensory neural hearing problem. Kind of thing to cram the day before the exam because you keep confusing yourself about it. Weber's test localizes to the left ear, but the Rene's test is negative on the left ear. Bone conduction is better than air conduction. What does this mean? Anyone want to tell me? Exactly. Why is that happening? Because the left ear is using conductive hearing, is using bone conduction. When you do the web, it localizes that ear, but the negative RNA says there's some conductive hearing loss somewhere. Cool. So memorize this. Okay, random buzzword times. Oligoclonal band on the CSF, but not in the serum means? Cool. Chorea means? Perfect. Donald Duck speech? What's Donald Duck's speech? What? Pseudobulbar palsy, which is, bulbar refers to the nuclei of the motor cranial nerves other than the eyes. It can be caused by a stroke to the brainstem, MS, or motor neuron disease. There's a specific type of motor neuron disease called pseudobulbar palsy where that's actually just what it affects and just degenerates. Shit. 3 Hertz spike and wave discharges on EEG. Perfect. All right. 40-year-old woman has a mass in front of her, the neck. Mass moves with on palpation, the mass is hard and irregular. The woman says she has developed hoarseness of voice, presumably, for the last 3 weeks. Someone want to say it louder? Yep. Okay. So hoarseness of voice, mass in the thyroid, everything's pointing to recurrent laryngeal nerve. I would memorize all of these nerves because chances are if it's going to be a nerve problem, it's going to be one of these. It'll be the same EMQ. All right. Nathan again. He's 67 years old. He's not being himself recently. He's got cognitive decline, in particular memory loss. He's incontinent of urine, has a crappy gait, short shuffling steps with a stooped posture and a broad base. No tremor. Yes. Okay. You clearly know too much neurology. You shouldn't be here. Normal pressure hydrocephalus. Really is just a random buzzword. You probably would never have heard about it. The mnemonic is weird walking water. They're weird, so cognitive dementia-like symptoms, but very quickly progressing, only a few weeks. Walking gait and water, they're incontinent of urine, so they've got a crappy gait and they're peeing everywhere. Alcoholics, you should know about alcoholic withdrawal. It's 2 to 3 days after they stop. They get agitated, shakes, irregular, heart rate sweating, and can lead to a seizure. Car dealers tend to be alcoholics. Take that as you will. Okay, Wernicke-Korsakoff syndrome, probably should know the triads, or at least be aware of them. It will just be an EMQ. Okay, this I don't understand why they put it in third-year exams. Cesarean sections are fourth year, but she's had a elective cesarean section, and she's having difficulty holding her arms up to lift her baby. Sorry? Someone's told you? Yep, the answer is a high spinal anesthesia. They went too high and paralyzed the arms as well. Why you need to know this? I don't know. Just know it. Okay. Severe pain on one side of the face in mandibular and maxillary region. Hurts like hell to wash face and brush teeth, and wind causes pain. Trigeminal neuralgia or tic douloureux. Carbamazepine is a treatment. Sudden onset facial droopiness, also sensitive to sound and can't taste well. Forehead doesn't move on one side, which is called Bell's palsy. Okay, so pred within 72 hours, and remember eye protection. They get cranial ulceration. So forehead sparing is the really important thing. Stroke is bad, but it looks better because the forehead is fine. Doesn't make any sense, but that's the way it works because the forehead gets bilateral innervation. Okay, also you'd expect lots of other things in the face to be affected in stroke. Remember that in Bell's palsy you can get reduced taste and sensation around the ear and hyperacusis as well. All right, cool, we smashed through all of that. So to conclude, guys, those slides have everything you need to know in neurology. You don't need to know angular gyrus causes any problems. If you do, great. Not criticizing you, but you don't need to know that kind of detail. I'll put up the full slides. Just look through the little things I've got. That is literally everything you will need to know. And I focused on the OSCEs at first because that's the thing you have to recall. You have to really come up with on your own those OSCE questions. Everything else is pattern recognition. And it will be fairly straightforward on the EMQ. And revising a little bit of neuroanatomy and your exams. All right. Please don't hesitate to ask me if you have any questions about this or anything else in third year as well.
And thank you to Nathaniel Lizak for that amazing lecture. For all those watching at home, good luck and good night.
All right, thanks for coming.